Welcome to the Human Health Campus Paediatric Nuclear Medicine webinar series. This webinar is entitled Pediatric Non-Oncologic Bone Scintigraphy and is presented by Claire de Labriolle-Vaylet from the Department of Paediatric Nuclear Medicine at the Trousseau Hospital in Paris. I am pleased to present this seminar to you on behalf of the Nuclear Medicine and Diagnostic Imaging section of the International Atomic Energy Agency in collaboration with the European Association of Nuclear Medicine.
Most of you routinely practice adult bone scintigraphy, in which the most frequent indications are cancer-related. In contrast, most children are referred for non-oncologic indications. The most frequent indication is suspected bone infection. At the beginning of an acute infection, plain radiography is usually normal, but a bone scan can provide visual proof before starting long-term antibiotic treatment. When a child is limping, the bone scan may also reveal a fracture or benign arthritis or Legg-Perthes disease. Chronic pain on the legs or back is frequent and may simply be related to growth, but it's important to eliminate a bone disease. The possibility of whole-body screening is a great advantage in nonverbal children, that's to say very young or mentally disabled children. It's important too in case of suspected child abuse. Because radiopharmaceutical uptake is a function of bone vascularization, bone scintigraphy is an excellent tool for evaluating the viability of bone tissue. First, a few technical points. Before all injections, topical anesthesia is used to avoid pain, for instance with EMLA cream placed on the back of the hand or elbow fold about 90 minutes before the injection. Good hydration with water or milk accelerates tracer elimination. The radiopharmaceutical is the same as for adults, a diphosphonate labeled with 99M technetium. The dose is determined using the pediatric dosage card provided by ESNM. It's available under open access on the ESNM website. The tracer is injected directly by the intravenous route. During the acquisition, the child must be immobilized gently but firmly. The child must be comfortable and a parent should be present. Allowing the child to watch a DVD helps to keep him still. We do not use sedation or anesthesia. Two acquisition protocols are possible. The intravenous injection is usually more difficult in children than in adults. It also takes longer, so a two-phase acquisition with a blood pool acquisition performed 5 to 10 minutes after the end of the injection is usually easier than the three-phase protocol. There are cases, however, when the vascular phase is really necessary, for instance, in suspicion of reflex sympathetic dystrophy. Cooperative children should be encouraged to urinate prior to imaging. It's always important to image the whole skeleton. In young children, multiple spots are preferred. As good resolution is mandatory in children, the collimator with the highest resolution should be chosen. The energy window is 20%. The pre-time is usually 300 seconds. A zoom may be used according to the child's size. Don't forget to begin with the pelvic view before the bladder fills up. When the child is older than 8 years or is a teenager, the whole body scan can be performed at a rate of 12 cm per minute. SPECT is recommended for adolescents with a spinal, pelvic or skull disorder. It can be difficult to perform tomography in young children, but other views are possible: oblique, profile, penile acquisition. This is the normal skeleton of an 8-year-old boy. Uptake is high on the epiphysial plates, which are highly vascularized and have high rate of bone formation. Normally, the limbs and joints show symmetrical uptake. Before dealing with pathologic situation, I must stress the changes that occur in the growing skeleton. For instance, the navicular bone is not visible before the age of 2 years. On the pelvis, around the age of 6 to 10 years, ischiopubic synchondroses may be visible and are sometimes asymmetric. They must not be confused with fractures or infection. A very interesting atlas of the developing skeleton has been published by IAEA and is available free of charge. You can find its references at the end of this course. Diagnosis of bone infection in children is a real challenge, especially because a misdiagnosis can result in long-lasting functional problems. Biological signs of infection are often very discreet in children. One of the most useful analytes is C-reactive protein. Plain radiography is normal during the first week of bone infection, and a normal ultrasound examination does not rule out infection. In an infection context, the bone scan is very sensitive and can be used to guide MRI, which is often difficult in children between 1 and 5 years old. In the case of osteomyelitis, the most frequent scintigraphic aspects are hyperemia on the blood pool image and increased tracer uptake on the bone metaphysis on the delayed images. In the youngest children, arthritis is more frequent than osteomyelitis. On the left side of this slide, you see the delayed view of right ankle arthritis with increased tracer uptake on both the tibial metaphysis and the talus. The right side of the slide shows the scintigraphic aspect of right shoulder arthritis. Be aware that cold images may be observed in case of bone infection. Here is a picture of a 5-month-old baby with left shoulder arthritis. The upper part of the humerus is not visible and the diaphysis is very heterogeneous. How does bone necrosis occur? Infection leads to inflammation and increased intraosseous pressure. Blood stasis combined with the action of bacterial enzymes creates a risk of thrombosis. Bone necrosis can occur as well as abscesses. Cold images may also be observed in case of high pressure in an infected joint. Spinal bone infection or discitis leads to rectangular increased uptake in the bodies of the two vertebrae on each side of the infected disc. In the first years of life, the first phase of spine infection is often discitis. This is a specific pediatric entity, as blood vessels feed directly into the intervertebral disc until the age of 5 years. The symptoms of discitis are the same than those of spondylodiscitis. In particular, young child refuses to sit. A bone scan may be normal due to a lack of radiopharmaceutical uptake in the disc. The typical scintigraphic findings sometimes occur only 7 days after symptom onset. Discitis is treated with antibiotics. On the blood pool view, you can see a small area of hyperemia on the left side of a lumbar vertebra. The delayed posterior view shows a hot spot in the same place. These are the scintigraphic signs of early stage spondylodiscitis. In summary, the bone scan is a sensitive screening tool for suspected infection, especially in youngest children. Its main limitations are, first, that its sensitivity is better for osteomyelitis than for arthritis. Second, that it's most informative 2 days after the onset of infection, and third, that it's less informative when antibiotics have been administered for more than 5 days. It's therefore important to do the bone scan during the first days of treatment. MRI is needed to image paravertebral abscesses and spinal cord compression. Limping in a child may also be due to a hip problem. Transient synovitis is the most frequent cause of limping before the age of 5 years, while Legg-Perthes disease is more frequent in older children. Epiphysiolysis may occur after 10 years of age, especially in boys. Bone scanning is not done routinely in these hip disorders, and children are referred only when the diagnosis is doubtful or when bone viability needs to be assessed. The use of a pinhole collimator increases image resolution. The pre-time of 10 to 15 minutes may be an obstacle in very young children. On the left, you see the scintigraphic aspect of left hip synovitis with faintly increased tracer uptake by the joint. On the pinhole acquisition, the left femoral epiphysis is homogeneously perfused. In Legg-Perthes disease, the femoral head is not perfused in the early phase, but the growth plate is clearly visible. During the healing phase, increased tracer uptake with triangular shape gradually appears on the external face of the femoral head. The diagnosis of epiphysiolysis is radiological, based mainly on profile views. The femoral epiphysis axis is turned inwards relative to the femoral neck. As this process is usually slow, perfusion of the femoral head remains normal. Vascular injury may occur after surgical treatment, which consists in maintaining the femoral epiphysis in the right position with a screw. This example shows necrosis of the left femoral head after surgical treatment. Fractures may have the same aspect in children as in adults, but there are some specific pediatric features. Toddler fracture is a spiroid fracture. It occurs after tibial torsion, either during a fall or when the foot is stuck between two crib bars and the child turns sharply. There is no bone displacement as the periosteum is very solid in children. Plain radiography is usually interpreted as being normal. The blood pool image and delayed image show moderate homogeneously increased tracer uptake on 2/3 of the tibial diaphysis. Sometimes the fracture is less extensive, creating only oblique hyperfixation on the middle third of the diaphysis. Other fracture sites are frequent in the limping child, particularly fracture of the cuboid bone or calcaneum. The traumatic event cannot always be identified, as children can't be watched all the time. Spondylolysis is a bone fracture of the posterior part of a lumbar vertebra. It's well known in adolescent and young adults, but can also occur earlier in life. Indeed, 4 to 5% of 6-year-olds have spondylolysis. The diagnosis is usually based on plain radiography. A bone scan may be prescribed to rule out early-stage spondylolysis in a patient with lumbar pain, or to date the onset of spondylolysis, as only recent onset forms lead to increased bone tracer uptake. Scintigraphy becomes negative after 6 months, whereas plain radiography remains abnormal. This plain radiograph shows a fracture of the L5 pars interarticularis. In case of recent onset, tracer uptake is more intense, as shown on this image of the right side of the spine. Note also the abnormal tracer uptake on the left side, which is more discrete and therefore probably older. Bilateral forms are frequent and destabilize the vertebra, which may be displaced forwards. In an adolescent with lumbar pain, planar radiography can be nearly normal. Tomography of the lumbar spine is thus mandatory to rule out epiphysiolysis in a child with lower back pain. One great success of bone scintigraphy is in osteoid osteoma. When this benign tumor develops on the spine, scintigraphy shows a spot of intense tracer uptake on the vertebra located in the concavity of the scoliosis created by analgesic muscle contraction. An osteoid osteoma located on the upper third of the right femur, with a focus of intense tracer uptake, surrounded by a periosteal reaction clearly visible on plain radiography. Osteoid osteoma of the left tibia, surrounded by fusiform tracer uptake. CT clearly shows the active center of the tumor and the surrounding periosteal reaction. Some patients are referred for whole-body scan because their pathology could affect the entire skeleton. Here is an example of a whole-body scan in a patient with sickle cell disease. Note the heterogeneity of the diaphysis and of the epiphysis of both knee. Note too the necrosis of the right femoral epiphysis. In sickle cell disease, bone infarcts can occur on the femoral head and also on the pelvic bone, as seen on the right-hand view. Fibrous dysplasia may occur early in life. The disease may be localized, as on the left-hand view, showing only involvement of the cheekbone. It can also be diffused, as on the right-hand view. Some suggested reading. Clinical case 1. A young boy is referred for a bone scan because of right knee pain and fever. The C-reactive protein is elevated and plain radiography is normal. Here are the results of two-phase bone scintigraphy with the blood pool image and the delayed image. What's your diagnosis? Four proposals. Make your choice. It's osteomyelitis of the left femur with increased tracer uptake of the femoral metaphysis, also extending to the diaphysis. There is no knee arthritis because there is no increased uptake on the tibial side of the knee. Here is the scintigraphic aspect of knee bursitis. The blood pool image shows hyperemia of the left knee, but the delayed view is normal without abnormal bone uptake. Clinical case 2. A 12-year-old girl is hospitalized for ankle arthritis. She has persistent fever after 2 days of intravenous antibiotic treatment. Here are the blood pool view on the left and the delayed view on the right. What's your diagnosis? The talus is not visible on either image. Note the bone necrosis secondary to infection. If the radiopharmaceutical cannot diffuse into bone, neither can an antibiotic, making the intravenous treatment ineffective. Clinical case 3. An 18-month-old girl is limping after a fall and also had a high fever. She is referred for suspected bone infection. Do you think these images favor osteomyelitis? No. The first hypothesis is toddler fracture, and this is confined by plain radiography oriented by scintigraphy, showing a clear line on the tibial diaphysis. Toddler fracture classically occurs between the age of 9 months and 2 years after leg twisting with the foot blocked. If the child is very young, bear in mind that the fracture may be due to child abuse because such young infants are not strong enough to twist round on their own. Clinical case 4. An 11-year-old boy has been limping for a month and has pain on the left ankle and knee. Reflex sympathetic dystrophy is suspected. Do you think he may have left-sided reflex sympathetic dystrophy? Yes, he has cold reflex sympathetic dystrophy with decreased blood pool of the left leg and decreased tracer uptake on the delayed view. Cold reflex sympathetic dystrophy is a specific pediatric aspect which I have never seen before 8 and after 15 years of age. The pain often occurs suddenly with no trauma. The prognosis is usually good with more rapid symptoms resolution than in adults. I hope this presentation will help you with pediatric bone scintigraphy. Thank you for your attention.